Sorry guys, we are live now.
Good day to all of you. Thanks for joining this session on humanitarian agencies and aid in conflict affected settings. I think we have a very interesting session with 5 presentations, and most of them come around a single theme, which is essentially addressed in the second one. It has something to do with the humanitarian development nexus. So let's get started as soon as possible. We will run the 5 presentations in consecutive order, and then at the end there will be time for questions and answers. So I would like to promote that you will start posting questions in the Q&A box, so that we could see what's coming in and which one we can attend to at the end. So please don't wait for this. Some presentations go very fast, so you have to really be on top of it, but try to think it through and pose already your questions. They will come back at the end. So as first speaker, I would like to introduce Sami Al-Awlaki. He is from Yemen. He did a study in the evaluation of the national health cluster performance in Yemen, and he's from the Robert Koch Institute. At least that's what he gives now. He has multiple affiliations, so he will introduce himself. Please start the video of Dr. Sami.
Okay, so good morning, good afternoon, ladies and gentlemen, and welcome to this presentation. In this presentation, I'm going to present the findings of a study I have conducted last year. It was about the evaluation of the national health cluster performance in Yemen. And as you know, Yemen is a country within the Middle East. It's considered as the poorest country in the Middle East. It's bordered by Saudi Arabia and Oman, and they occupied a strategic position within this region. Since 2015, the country has been struggling with an internal conflict, and then this conflict took an international perspective after the interventions of other countries. The study was basically designed to evaluate the health cluster performance in Yemen between 2015 to 2018. And the health cluster is a coordination platform. It's led by the United Nations Office for Humanitarian Affairs, or UN OCHA, with an aim to coordinate all humanitarian interventions within the health cluster or within the health response. The health cluster has been in operation since 2011, and I wanted to see to evaluate its performance between 2015 and 2018. I had 4 questions, which were about the effects and of the health cluster, and how the effectiveness of the health cluster, and what are the aspects that can be improved, and what was the reaction of the health cluster to the division of the government, and also how did that affect the performance. I employed qualitative research design using purposive sampling. I interviewed 10 people from mostly health cluster coordinators, United Nations UN staff, or those who are working for national or international organizations. I also use mostly online or face-to-face interviews for those who are living abroad. But most of the participants, they were from Yemen. I applied a NAB evaluation guide, which is a very known guide to evaluate humanitarian action, to evaluate humanitarian action in emergencies. It is, and also with a modified development access criteria. I used 6 criteria. I will come to that later when I present the findings, and the data was analyzed by in vivo. So the first 2 criteria I've assessed were the relevance and effectiveness. So what went well with regard to the cluster is there were relevant objectives. So the cluster objectives that were very relevant, and the cluster itself prevented deaths, and there was adequate level of coordination, and the basic health service also have been expanded. On the other hand, the primary focus was mostly on life-saving interventions, and there was less attention was given to health system support, so to say. The strong level of centralization, in the sense that the health cluster is strongly centralized in the capital, in areas held by the rebels, while the peripheral hubs, they were lacking decision-making power. Some participants mentioned that there were interference from some organizations. and also for the national authorities, which affected the neutrality and independence, and the lack of timely response once there is a crisis. That was one of the issues, and that was because of the long bureaucratic procedures. Here is a comment from one of the participants mentioning that this was an issue that he felt during his work or hard work. With regards to effect and participation, what went well is the support to health facilities and the improved information system. There was less duplication, and the cholera response was one of the highlights of the health cluster response. On the other hand, the lack of decision-making power to subnational hubs was one of the negative issues encountered in the last three years, and the suboptimal or the less participation from national NGOs or national non-government organizations. They lack the power to participate and to actively engage in the activities. With regards to connectedness and efficiency, what went well was the capacity building activities, especially for community health workers, which help the health system, to sustain, or the health services to sustain on the long term. On the other hand, the explicit exit strategies were lacking, and the funds available were less than the needs, and there wasn't direct funding mechanism to support health interventions during emergencies. So the health cluster, each time it has to go through a specific donor mechanism in order to release funds. Some participants mentioned that some interventions, such as mobile clinics, may have a negative effect on the long term, so because they are not sustainable. So these are the basic results. With regards to the recommendation for policy and research, based on the participants, they suggested to review the process of health cluster objectives and to indicate more clear exit strategies. An independent financial mechanism also would be ideal. This would enable the health cluster to respond directly whenever there is a health crisis, instead of waiting for donor agencies to release funds, which is normally a long procedure. Health system recovery plan, this can be agreed upon between the Ministry of Health and also the all health stakeholders. And this also will give, because now the conflict is sort of protracted, so it is very important also to have this long-term vision on what would be the future of Yemeni health system. Gender, some health participants mentioned that the cluster coordinators were mostly male, and they advised that they wanted to see more females in this role, especially at the central level. Economic and impact evaluation and role of observers should be explored as well. For example, MSF and ICRC. The role also has to be explored because they are not active participants. They're taking an observer role. On the other hand, they also provide a massive health response in Yemen. So to conclude, the health cluster response was effective because it saved lives and prevented duplications of humanitarian efforts. Some areas need improvement though. The reaction to the government, the health cluster reacted by forming subnational hubs, and it also worked in collaboration with the Ministry of Health. So it didn't address the division directly, so to say. There was also delayed and non-harmonized response in some occasions. The effects of the health cluster was obvious by supporting the health system, improve the preparedness capacity, and also building the capacity of the local health workers. And the highlight of the health cluster response during the appraisal period was the cholera response. What can be improved? I would say more delegation, or based on the participants, of course, and based on my analysis, more delegation to the national sub-hubs, and also more autonomy to these structures, availability of direct funding mechanisms that can be used directly, and better engagement of national organizations, national health stakeholders. So at the end of this research, I would like to give a massive thanks to Professor Majanet Tambor for her invaluable support throughout my research. And special appreciation also is given to the European Commission's Erasmus Mundus Excellence Scholarship for funding my research during my time in Sheffield in the UK, in Krakow in Poland, and in Rennes in France. And thank you so much. And if you have any questions, feel free to get in touch. Thank you.
Thank you very much, Saleh, for this excellent presentation. I think what you do touch upon is both the the life-saving aspects of the humanitarian response, but also you make a clear plea to work more on health systems recovery. Well, that seems to really set already the stage for our next presentation, which will be about the triple nexus. Just let me remind all the ones who are listening, if you have any questions, please post them in the Q&A box and we'll address them at the end of the 5 presentations. So over to the second presentation, which is will be presented by Elske Kuhlmann from Integrity, and she will examine the triple nexus. Over to you, Elske.
Good morning, good afternoon. My name is Elske Kuhlmann, Business Manager at Integrity. Integrity is an international development consultancy providing monitoring and evaluation, research and learning services in complex environments. We do this across a range of thematic areas, including health. Today, we will present the paper Examining the Triple Nexus, Desk-Based Research on Strengthening Humanitarian and Development Stakeholder Coordination for Health in Fragile Settings. This work was commissioned and funded by the WHO to provide advice to the Universal Health Coverage 2030 Technical Working Group. This presentation provides Integrity's summary of our review and the work we did. The work was conducted by a small team of Integrity colleagues and consultants, including Katie Bigmore, Principal Expert Male in Health at Integrity. It is often the case that humanitarian coordination mechanisms and government-led health development coordination platforms are not structurally, strategically, and operationally linked, even when there are common actors between them. This disconnect leads to inefficiencies, including fragmentation and missed opportunities for more strategic programming to strengthen health systems and improve service coverage and health outcomes. Over the years, there have been growing efforts to improve health coordination, both during humanitarian emergencies and development programming. Improved coordination is recognized as a crucial function to promote joint working and ultimately support better health outcomes. The focus of this study was specifically on coordination across the humanitarian and development interface. The study also examined, although to a much lesser extent, the links with peace-building actors. The triple nexus refers to the interface which links humanitarian, development, and peace actors. Our review examined the lessons from working across the triple nexus so far and identified a set of enabling and constraining factors that affect coordination in practice. To understand the factors that enable and constrain effective health coordination between humanitarian development actors and identify evidence gaps, we consulted multiple data sources. This included reviewing available literature, reviewing existing documents, policy commitments, guidelines and tools, and conducting key informant interviews with experts in the field. As part of the literature review, we reviewed purposefully selected literature from existing documents shared by the UHC 2030 Technical Working Group, Core Group, and the key informants. A total of 15 key reports and academic journals were consulted for the review. As part of the document review, we conducted a rapid mapping of the policies, guidelines, and tools which touch on coordination of health responses in fragile and challenging operating environments. We first identified and reviewed existing policy commitments and principles that are relevant to humanitarian development coordination, including those that are specific to health, as well as others that apply more broadly. This provided a helpful understanding of the policy context and any pledges made on coordination. Additionally, we collated and reviewed existing tools, guidelines, and assessments that are currently used in the humanitarian and development spheres for design, planning, implementation, and evaluation. We aim to understand the extent to which these tools serve to promote improved health coordination across the nexus. The purpose of the key informant interviews was to gain insight from different stakeholders' experience with coordination mechanisms, in particular coordination across actors in fragile settings, to discuss and identify factors promoting and/or constraining effective coordination based on practical delivery experiences and in different country contexts. We conducted 12 key informant interviews with senior experts from a range of different actors working across humanitarian, emergency, peace building, health system, and development programming and academic research. The review helped gain new insights and build understanding of the key factors affecting health coordination and ultimately improve universal health coverage in fragile settings. The review identified a set of 25 enabling and constraining factors that affect stakeholder coordination across the nexus. These factors can be grouped into 5 key determinants, which are local context, ways of working, who is involved, how information is shared, and institutional constraints. This desk review has found that there is a growing body of work on the triple nexus supported by multiple organizations and across multiple actors, including various work streams in WHO. Overall, efforts to strengthen coordination to improve health outcomes in fragile settings is recognized as very necessary. While new policies and tools to coordinate effectively between actors working in challenging settings are welcomed, it appears that operationalizing them remains a challenge. A more detailed understanding and guidance on how to practically apply certain principles is needed. There are challenges around the limited availability of evidence and absence of documented lesson learning on the topic of improving health coordination for universal health coverage in challenging settings. The peer-reviewed studies that do exist tend to be observational with weak study designs and often with a very specific focus. Relevant lessons and evidence that are being generated at a local level are not captured and shared. The desk review highlighted a number of emerging issues that help to understand this topic in greater depth. It consolidated all the findings into a list of key factors that affect stakeholder coordination across the humanitarian development peace nexus. It suggests that investing in understanding and improving these factors will in turn lead to improved health outcomes and contribute to universal health coverage in fragile settings. During COVID-19, it will be critical to work across the triple nexus. At present, the nexus approach appears to be almost absent in the response to COVID-19. There is a real opportunity to look at better coordination and engagement across the development, humanitarian, and peace actors, and to ensure a holistic approach which looks at both the immediate and long-term needs as countries grapple with the pandemic. Thank you.
Thanks for this presentation. It's a good overview of what we are talking about when we're dealing with the triple nexus. That's good as an overarching framework, in fact, for all of this session. So that's very relevant. And we may hear a bit more later on what your factors, in fact, were that you have been identifying. Again, questions will be at the end, and we'll move on with the third presentation. And that's, as already was alluded to in this current presentation, we often talk about the triple nexus, but in reality, we often only focus on humanitarian development, and we forget a bit about the peace part of the triple nexus. So then it's very pleasant to have a presentation which in particular also focused on that aspect. And for that reason, we go to the other side of the world, to a part of the world which is, of course, highly in the news these days, which may, in fact, even inflict on this presentation. I'm not sure. It's a presentation which was not built over the last week, so obviously, but it's called Building Bridges Through Primary Healthcare, Case Study of Engagement with the Health Systems on Both Sides of the Conflict in Myanmar, which will be presented by Tom Trail together with Dr. Kain Wai-Wai-Oo. Please go ahead.
Hello and welcome to our session today. We're going to explain about a case study where we're extending health access across conflict lines and in areas of different government controls in the southeast of Myanmar. My name is Tom Trail and I'm the Director for Research and Policy at Community Partners International. And my colleague is Dr. Kain Wai-Wai-Oo, and she'll also be presenting. She's the Director for this project itself. So I'll give some context to start with. The Myanmar Civil War has been ongoing since 1948, and it's even prior to that in the conflict was for the independence of Myanmar. And while the most known at the moment internationally is the Rohingya crisis, the expulsion of the Rohingya was just the latest in what has been ongoing displacement and conflict affecting many of the ethnic minorities all over the country. Next slide. So today, the fighting is fiercest in the west, in Rakhine State, but now with the Arakanese Buddhist minority fighting against the government instead. They're still fighting in the north. And then in the eastern border, there's a patchwork of ceasefires, but significant areas remain outside of government control. The peace process delays mean that these aren't formally defined yet, where land is responsible for who. The health needs in these areas are also the greatest because conflict has directly impacted health and it's also meant less socioeconomic development, which also would have improved health. At the same time, the government health service is weakest there because of conflict meant they couldn't access it. So the need is greatest. During the Civil War, the ethnic armed organizations who are fighting the government, though, did set up their own health systems, known as ethnic health organizations, or EHOs. And these were mostly mobile because of fighting, but with ceasefires have become more clinic-based in the non-government controlled areas in the southeast. So the big question is how to provide health for all when the authority is split between these ethnic armed organizations and the government. And this project, which we're focusing on, is run by the Swiss agency, or funded by the Swiss Agency for Development and Cooperation. And it supported the health systems on both sides of the conflict. So from the government side and from the ethnic armed organization or ethnic health organization side. And the aim is to improve both the systems of both and then also to facilitate the coordination between these two systems. And I'll hand over to my colleague, Dr. Kain, to explain a little bit more about this project in particular. Dr. Kain.
So our case study project is funded by Swiss Agency for Development Cooperation and implementing by two consortia. So our organization, Community Partner International, is working together with ethnic health provider, while Save the Children International working with the government and the other CSO. So now we are in the phase 2 now, and our project is aimed to make equitable health provision, community empowerment, and also the strengthening the health system for both government and the ethnic health organization regarding to the assessment pointing that like a health and the emergency related issue in this area. So our project serves 286 population at 548 villages through 80 primary health facility run by ethnic health provider. So this project is support the peace process and also can foster the coordination and the collaboration between both government and the ethnic health organization side. So this project is support both government and ethnic health organization in order to integrate the parallel health system. So under this project, we can provide the basic life-saving healthcare services to the underserved population. So whenever we implement the activity under this project, we always follow the conflict-sensitive program management approach. So now, where are we now regarding to the peace building? So I can say that from this project, we can make very first time activity together with both government and ethnic health organization, like a joint micro planning for the vaccination. And regarding to the referrals, so previously, most of the patients from ethnic health area can refer only to the Thailand side because of the lack of trust building between government and the ethnic health provider. But since the beginning of this project, the referral from the ethnic health organization to the government health facility seems to be improved. I can say we found that in 2012, only 30% of the patient can refer to the government health facility, while in 2020, it increased up to the 74%. Moreover, we can make some of the joint technical training, like reproductive, maternal, and child health training to other ethnic health provider together with the government health department. So our project, this case study project, is good for health, social cohesion, and also enhance the trust building at both community and the institutional level. So right now, all of you know, the whole world is impacted with the COVID pandemic situation. And also our project area and activity is also impacted a lot. But in Myanmar, most of the COVID pandemic response is centralized at both government and the ethnic health sites. So that's why it can make delay and reduce our existing cooperation and the collaboration between both sides. So I can say that sub-national gain remain vulnerable to the national shock. So my colleague Ton will continue to talk about how it can impact the elite level of learners.
So the big question which remains, thank you, Kain, is whether this local cooperation and trust building, what the impact will be on the national level peace dialogue. And we've seen that there have been these increases in trust, which have been facilitated through this project and have led to the things like the greater referrals and the joint planning. And we hope that this will include these kind of social effects in the peace deals, which are normally run by just the military. Next slide. I will finish with just a few of our key findings. I think one of them is that very few donor health programs really actively engage with the political impacts of health work. And we think this is a great example of looking at the scenario and the political context and the conflict context and trying to improve both that and the health situation at the same time. I think if they had just supported the government services, it would have been having an impact on the political context, as would working with just private or NGOs, whereas trying to work with both sides is really building something better as a result. We also hope that this can shape the peace process to take account of these social and community needs rather than just the sort of more military needs that those actually making the negotiations often consider first. So we think we can make a better peace deal. And the conclusion is, these projects are hard to do, but we think that they are worth it. And we think it really can improve things for the whole of the community as a result of doing this. Next. As we said, we think that this kind of a project can be this bridge to peace that can bring peace to the mountains on the borders of Myanmar. Thank you very much for listening today. Thank you.
Thank you both for this presentation. You can easily see it's hard work to work on both sides. It's easier to work on one side, so all the more good to hear about this and that you do believe this is making a positive contribution to peace. We may have some questions around that later on. But first we will conclude with our two remaining presentations. The next one is slightly different nature, but also very much to do with what happens in particular in fragile and conflict-affected states, most notable Nigeria and Afghanistan we will talk about. And that will be presented by Professor Svea Klosser from Johns Hopkins School of Public Health, called Social Justice Eradication Programs and Community Relations, Understanding Vaccines Refusals. It's all about polio eradication. So Svea, please, the floor is yours.
Hi, my name is Svea Klosser, and I'm at the Johns Hopkins Bloomberg School of Public Health. And this project that I'm going to talk about today is part of the STRIPE project, or the Synthesis and Translation of Research and Innovations in Polio Eradication, which is a collaboration of academics in 8 countries. So although I'm giving this presentation, I'm completely indebted to my colleagues for our collaboration on this. So today I want to talk about vaccine hesitancy, particularly in polio eradication, and how it's tied to social justice. So proponents of disease eradication have argued that because the approach benefits everybody on Earth, you have to reach every last child, it's the ultimate in social justice. But reaching the world's hardest to reach with an eradication program involves ethical dilemmas and trade-offs, including the question of whether to provide broader health services to those communities that you're reaching, in addition to trying to eradicate the disease. And that's a tall order because, as the Polio Eradication Initiative has learned, eradicating a disease is in and of itself extraordinarily difficult. So the work I'm talking about today, as I mentioned, comes out of a collaboration of academics in 8 countries. And Kunle Alonge here at Hopkins is the PI of that project. But we're academics from the US, India, Bangladesh, Indonesia, Afghanistan, Nigeria, the DRC, and Ethiopia. And we've all worked together on this project. And we've done about 194 interviews with policymakers, national level officials, and frontline staff in these countries. And this particular discussion today, I'm going to present material from Nigeria and Afghanistan. And that's because Nigeria was the last country in Africa with endemic wild polio, and Afghanistan is one of the world's 2 remaining countries with endemic wild polio. And despite enormous differences in context between Nigeria and Afghanistan, there are striking parallels and reasons for vaccine hesitancy in these 2 contexts, and that's what I want to talk about today. So when the Global Polio Eradication Initiative, when the goal of global polio eradication was adopted in 1988, routine immunization was one of the 4 pillars of that goal. However, over the intervening years in the 90s and early 2000s, there was a de-emphasis on routine immunization at the global level among the leaders of polio eradication. And that was due to concern over diluted priorities. They felt that polio eradication was difficult enough without also trying to increase RI at the same time. And at country levels, sometimes this emphasis was renegotiated by country governments. Some governments, like Ethiopia's, was able to use some of that polio funding to help strengthen RI, but that success was mixed, looking globally. And at the operational level, polio staff going door to door in many countries across the world listened to people's complaints about a lack of services, but in many cases were able to provide them only with polio vaccine. And that's what happened in some of the last polio endemic areas in Afghanistan and Nigeria. So the last of the world's communities affected by polio are socially, politically, and economically marginalized. Most experience some combination of conflict and migration, environmental hazards such as poor transport networks and flooding, and government persecution. And here we want to talk about the dynamics between these kinds of communities and the polio program in Afghanistan and Nigeria. So repeated doorstep visits by polio workers, polio eradication strategy in these communities is to go door to door and deliver polio vaccine. And these visits, repeated over decades, eventually led to refusals and resistance. You didn't see refusals and resistance right away, particularly not in Afghanistan. In Nigeria, one of our respondents said, quote, "People want food, and they're saying if we are committing a huge quantity of resources to address a disease, why did we choose one that's not even ravaging anybody?" Another Nigerian respondent said, quote, people were rejecting polio not because they didn't want it. They said, look, measles is killing my children. And when I went for vaccines for measles, you said you were out, you didn't have it. Why are you following me with polio, which as far as they are concerned is not as severe? Another Nigerian respondent commented, there's this misconception that there must be something behind it. So people started worrying about this sort of mismatch between, okay, you're coming to my doorstep with polio vaccine, but I can't get any services at all at the health center. Is there something else happening here? Is there something deeper going on? In Afghanistan, a respondent said, they complain about the services in public health facilities. They say when we are going to our hospital, we're not even considered human. They don't care what happens to our patients, even if they're dying, nobody cares. But you come to our house for polio, there must be something behind your insisting so much. So they doubt us. They say it's the same child, you come to my house to vaccinate him, but if we bring him to the hospital, you're not giving him any service. So this same dynamic you see in both countries. Similarly, the repeated visits in both places led to some hesitancy. So in Afghanistan, a respondent said, between 2011 and 2018, we had more than 10 campaigns every year. That means that we knocked on a door of a household 10 times a year to vaccinate the children. Now the community is tired of vaccination and they want change in the program. They request other things such as clean drinking water, access to other health services. Everything's repeated so many times and too much repetition has happened. A Nigerian respondent said, quote, the challenge we are facing is the element of fatigue because we're vaccinating almost every month. We keep coming to the doors to treat the households every month and the people are tired. So actually in some areas, communities have attempted demand refusals in which the whole community refuses polio vaccine in an attempt to raise awareness of larger issues affecting them. And this is just sort of an illustration of this dynamic. So the polio program has attempted to address these hesitancy issues primarily by working through local influencers, and this has worked pretty well. So in Nigeria, a respondent said, where traditional rulers have a lot of power over their people, when you are able to convince the traditional rulership about the safety of what you want to do, about the importance of what you want to do, then they're able now to help you convince their people. A respondent in Afghanistan said, when mullahs declare in mosques that you can prevent your children from polio from 2 drops of vaccine, it has a positive result. So this has worked to some degree, but it doesn't address these larger social justice issues that are really underlying people's hesitancy and refusals. So recently, the GPEI has taken steps to provide broader health services in polio-affected communities, including partnering with Gavi. So this partnership with Gavi is new. This is a really important and very complex project. Building trust and eradicating polio in these communities will likely require broad service provision not achieved in these populations by any health program thus far. So I just want to give a huge thanks to my academic partners in the STRIPE Consortium, particularly my colleagues in Afghanistan and Nigeria for the work that they've done contributing to this project. Thank you.
Thank you very much, Svea, for this intriguing piece of work, going to those countries and seeing what's happening, why they refuse or hesitant. And I think it seems highly relevant these days to have this kind of findings because we all struggle all over the world with vaccination hesitancy for our new COVID. So, and I think some of the same arguments do come up. So your research may have a big impact on other things as well. So let's move on to our final presentation of today, which is coming from yet another part of the world, from Zimbabwe. Rashid Hamisi, who is himself somewhere out in the bush, but he's also represented by Jill Olivier. And he talks about the withdrawal of INGO funding from public health facilities in fragile conflict affected states. So taking a case study from Zimbabwe. So that seems almost also very much linked to this whole debate about the nexus, as we had done before. So Rashid, although we know you're not there, but you're there on screen, so please go ahead.
All right, my name is Rashid Hamisi and I'm a student at the University of Cape Town. I'm going to present a case study that we did in Cholocho District Hospital in Matebele, North Zimbabwe, titled "The Impact of INGO Funding Withdrawal from Public Health Facilities in Fragile and Conflict-Affected States." So if achieving SDG targets in fragile and conflict-affected states seems unlikely with contextual and historical drivers of fragility, namely civil wars, weak institution, weak governance, economic contraction, and low government expenditure on health. As a result, efficacy remain reliant on public-private engagements, usually with global partners and international non-governmental organizations. Zimbabwe has had decades of fragility and is largely dependent on GDP initiatives for health financing and service provision. So despite the need, there is an increased frequency in termination of PPE initiatives due to changes in global and local economic and social political drivers, and exploration of the implementation of the process of withdrawal of partner support is important in understanding the magnitude of system disturbances emanating from this process. We conducted a case study between 2018 to 2020 of the phenomena of withdrawal process of INGOs from Cholocho District Hospital. 3 cases were purposefully selected of termination experiences between 2009 to 2019, and we found out that first we divided our findings into 3. First, we wanted to find out the impact of the withdrawal of partner support, and secondly, we wanted to find out the challenges that were experienced during the withdrawal process, and lastly, how Cholocho District Hospital coped with the withdrawal of partner support. Firstly, there was significant loss of resources. Cholocho District Hospital was dependent on resources that were provided by international non-governmental organizations during these initiatives. So this compromised also other hospital programs that were reliant on resources that were provided by INGOs. For example, programs like sexual and gender-based violence and the hospital nutrition program suffered following the cessation of INGO resources. Secondly, the withdrawal of support from TDH was an acute shock to the health system. In all 3 cases, the withdrawal was abrupt and gave TDH little time to prepare or adjust to the loss of partner support. So even if all 3 international non-governmental organizations had different exit strategies, but the shock to the health system was acute in nature. However, the magnitude varied across cases depending on the scope and depth of program interventions. For example, the MSF intervention was more extensive, and consequently the shock experienced by the health system was greater after the termination of MSF. So we found out that also with relational and operational challenges. So there was unilateral decision making by most INGOs without consultation of local health managers. For instance, TDH only found out of ACT Zimbabwe's departure some months after the organization had left. We also found out that there was competing priorities which undermined the local health managers' level of involvement in the implementation of the withdrawal plan. For instance, the DHE had multiple tasks like like trainings and workshops, so they could not commit themselves fully to the withdrawal plan. And lastly, the interaction between the withdrawal plan and the context had unintended consequences. For example, due to the economic meltdown, health workers were looking for greener pastures. So most of the trained staff left, leaving TDH with no health workers to continue with some of the program activities. However, despite all this, the INGOs continued with their withdrawal plan, which was rather more rigid and unadaptable to the changing context. There was no alternative exit scenarios. So the takeaways from the study, we need to improve on the documentation of the withdrawals experiences, especially the local health managers, so that they can share these experiences with other stakeholders. And also fragile states possess some level of resilience, and perhaps it might be time to rethink the aid approaches. And in conclusion, we would like to emphasize that it is important to let local stakeholders take ownership of the withdrawal plan. Otherwise, what is intended to be supportive can become an additional stressor on less resilient systems. We thank you.
Okay, thank you very much for this presentation. Yes, it makes one humble that I have experienced myself to be in processes of having to withdraw from areas, and it's a very, very unpleasant process. And you have documented this from the case of the non-receivers of any assistance anymore, and it's it's usually a bad thing. So this completes the 5 presentations. So we would still have a bit of time to answer any questions if there would be any. I did not see anything coming in yet in the Q&A box. Also, the presenters, of course, are welcome to ask questions to anyone else. So let me start posing some questions, and I may start from the other way around. So start with the last one. I know that Jill is there to answer some of these questions. There was some alluding to in the last slide of how could we do things different based on the involvement in this study. Do you have already some ideas how things could be different? Because it is a dilemma. You have, as an NGO, you have funds, and you may be able to have your own funds, like MSF usually does have its own funds. So it's more a decision which is made at their headquarters. But other NGOs are totally dependent on donor agencies, and at one stage money dries up, and they try to not to hide this a bit, because they are still hoping. Sometimes they're also afraid to go, and that's why they sometimes just leave, because they in some more violent places than Zimbabwe, it might be even dangerous. So yeah, I don't know if in the process of doing this research, do you have already developed some thoughts how things could be different?
Sure, thanks, Egbert. So just briefly to acknowledge Rashid, who is the primary researcher on this. As you mentioned, he is in a very remote rural area in Zimbabwe and is demonstrating some of the challenges of working in these contexts. So I supervised the study. This is for a postgraduate master's thesis. And so just speaking broadly to it, I hope I can do it justice. I know what Rashid was finding was some of the major challenges of not just general development assistance withdrawal, but the challenges of withdrawal in these particular fragile contexts, and the differences of those experiences to what the broader literature says about the experiences of abrupt funding withdrawal. So he was specifically looking at abrupt withdrawal, so withdrawal of funding with very little warning on either side. And so the contextual challenges in these fragile settings were very often the major factor. So many of these funders and these NGOs had the best of intentions, and they also, most of them had plans in place for what to do in the case of withdrawal. But very often those plans were difficult to implement in the fragile setting, in the fragile context in which they were working in. And for example, there were also a lot of differences in perspectives from the NGO partners and the people who are left behind in the system as to what those withdrawal experiences were. So there were so sometimes the NGO partners were saying, oh no, the withdrawal worked very effectively and we had a plan and the principles in place. And from their side, they felt the withdrawal went very well. And from the system's perspective, although they didn't politely say so at the time, it was quite a major challenge. So I think there's something about the pragmatic, I mean, I can carry on about this, but I think there's something about the pragmatic considerations for how to think about these things in fragile contexts. So the need for more primary research of these kinds of withdrawal experiences in fragile contexts, better guidelines for what to think about and what contextual factors and challenges to look for when funding is withdrawn. Because I know Rashid was kind of mapping how more and more frequent, because of all of our reduction in development funding and our COVID and contextual challenges, they are more and more frequent with abrupt withdrawals of funding. And so learning how to work with that and learning how to build resilience in these fragile settings for that. And just one of his other findings was that very often the withdrawal of funding affected the broader system quite profoundly. So the NGO would be aware of what did or didn't happen with regards to that particular program, but they weren't aware of the broader rippled effects of the withdrawal on the broader system. And so keeping your eye on that broader system was also really important. I can carry on, but I've been talking for quite a long time, so let me pause there, and you can come back to me if there's a time for more questions and discussion.
Yeah. No, thanks, Jill. Yeah, that has some of the issues that work in isolation, which you see so often, and that's indeed what we have tried to get rid of. But the practicalities are always huge. What I will do, I have some questions for each presentation. I'll work my way backwards. But I see in the meantime also 2 questions coming in. Maybe more will come. So since I will work my way backwards, I will first go back to Svea, and then Myanmar, and then Elske, or if there's someone from to represent her, I'm not sure, because during that question, I would in particular like to look also at the question which comes in from Mary Hadley. I'm interested in the strengths of agencies and even personalities of individual organization in coordination activities. So if there's someone from Integrity, seem to be the first ones to try to answer, but otherwise we'll ask someone else to try and approach that question. Yeah, Svea, you talked about the hesitancy of vaccination for polio, and focused on those well-known cases. Unfortunately, Nigeria is better off now, but Afghanistan, we know Afghans always a bit of a difficult situation. I know it. I'm deeply involved there, but that still seems to be difficult to sort out. But if you now look at the factors which you have found in Nigeria and Afghanistan, you wonder, why did we as world, as polio community, manage to sort it out in all the other countries? What's so specific here that, because the factors which you mentioned here, you also think of COVID and stuff, so it happens in all countries, but why was it so pertinent in these specific countries? Do you have any answer for that, or if it's just a chance phenomenon which happens?
Yeah, no, I think there is an answer. First, I want to just thank Yodi Mahendrata, who is here in the audience, who is part of the Strike Consortium. So thanks, Yodi, and welcome. Yeah, I mean, I think that there are, first of all, I don't think Afghanistan and Nigeria are unique in this. They were the two from our list of 8 countries that had these dynamics, but you see the same thing right now in Pakistan as well. So basically, these dynamics have arisen everywhere where the polio program has been doing large numbers of campaigns over a timescale of about 20 years. These hesitancy issues didn't arise right away. They developed over time with repeated campaigns over many years and the absence of other services. So why didn't we get to this point in some countries that have equally poor services is a great question. And I think the answer to that really has to do with poliovirus epidemiology. In some places, it was just much easier in places that have low population density, where the climate wasn't quite as great for poliovirus. There are certainly many settings where it was just easier to eliminate polio. With fewer campaigns over a shorter time scale. So it's these areas that have weak health systems, strong poliovirus transmission. It comes together to create this scenario where if you don't strengthen health systems over 20 years, people become quite frustrated with the polio program. So it's a time issue. It doesn't happen right away, and it has to do with the comparison between those two things.
Yeah, thank you. I never thought of that. That's the background epidemiology of it. That plays a role as well. Yeah, that's intriguing. Yeah, because there's so many other difficult places in the world where you would think things would happen as well. Just think about a big country like the Congo or the DRC.
Sure.
But apparently, we were more successful there. Yeah, then we had the case study on Myanmar on the peace building, the P of the triple nexus. I know Tom Trail is there to talk. I'm not sure about the other presenter, Dr. Kanawai U. But I would have this question for you. And we have been discussing this whole idea of could you promote peace as well through health activity, and health through peace, or peace through health. Health as a bridge to peace. Those kind of programs have been around in the past. It comes a bit in waves. They come up and then they disappear again. But I think you present another example where you have a concrete example where you have, in fact, you're working on it. In some of the debates about earlier work, and attempts, was always this feeling, well, it might be to some extent successful, but is it big enough to really impact on the bigger peace issues at stake? Because there's a lot of at stake and big politics, big monies. Do you manage? But so I think you have the idea that it does help. But I was wondering, not only that, could you say, well, it does help on the bigger picture, because that's very difficult to answer, but have you seen from your initiative to do this for health that also other sectors, in fact, are starting to do this? Because you can think that if more sectors would work similar, that would have that maybe effect at that higher level scale, which is obviously also needed to have peace processes going on.
Hi, Egbert. Thank you very much for that. My colleague, Kaimwe is not, the internet is unfortunately not sufficient to get on to discuss at the moment, but she's been sending also messages. So we're in touch, and so we can also find out what it is from Myanmar if necessary. Just in terms of your question, in terms of will it make that bigger impact? I think that's something which to an extent we weren't always hoping for. It wasn't the sort of key priority that this on its own or even in tandem with other health things would be the thing that moves it over. But we were thinking that in order for that piece to be sort of stronger and more sustainable, this would also be a key factor at a local level that this would change the peace relations. There are very similar efforts in education, and actually to some extent they have moved a little bit faster in terms of the cooperation between the government and the ethnic armed organization sectors, which we did not expect. We thought that education would be more politically fraught often. And I'd say that one of the potentially key areas relates to Mary Hadley's questions, that these personalities are very important in these peace building efforts that we have done. We've focused quite a lot on building these relationships, and in education, those relationships move quite a bit faster than in the health sector, where there's much more of a sense of propriety often, I think, around doctors and giving approvals for different types of trainings to be permitted. That kind of thing, the actual health technical areas actually slowed down these kind of improvements in cooperation we might have otherwise seen. But I completely agree that health on its own may not be a factor when there's other big issues. I mean, there's a lot of money from illegal trade, particularly in narcotics from Myanmar, and health and things don't end up removing all of those areas and stop them. You know, they're not going to solve those problems. Plus, there's of course the fact that the context has somewhat changed. I mean, the conflict we were talking about, even in the presentation that we recorded 6 months ago, is no longer the conflict that is currently happening. We were talking about government and ethnic armed organizations relationships. It's now a question of military versus people. So we are, yes, it of course wasn't sufficient at this point. We're trying to figure out where the next steps are to go. At the moment, we're doing very much what was seen in Zimbabwe. All the NGOs are taking their money out and stopping all support for government. And then the government staff are also stopping supporting the government thing. So there's strikes in basically all the hospitals and facilities. We're waiting to see how things pan out and how these kind of projects have to adjust and shift their scope. Yeah, I'll leave it for now, but happy to follow up more if necessary. Thank you.
Yeah, no, thanks, Tom. That's indeed some good remarks on putting that in perspective. Let's move on. Just another interesting comment coming in. You may already want to read it because I'll definitely come back to that one and ask Svea to respond. But I don't think we have anyone from the Integrity on board, do we? I'm asking to the conference room organizer. We had presenter could not be here, but she would be replaced by Katie Bigmore, but I don't think she's there. So no, that's we can't ask that question to her. So, but fortunately, Sameh, who also had some difficulties to coming, it's really a bit of a challenge to discuss fragile states and do it all over the internet because of the very nature of internet connections. But Sameh was back in time to be on board. I think you're there, Sameh. Yeah, I can see you now again. So we had listened to your presentation. What is particularly troubling me? That's not the right word, but so of course I have never been to Yemen, I must say, unfortunately. But of course we do hear about it. We have in my institute, we have a lot of students always from Yemen coming. Discussions around it and contacts with Yemen. But there's always this, for me, discrepancy in how Yemen comes across to us in the news. Big mess, fighting going all over the place, huge degree of starvation. In fact, many people are having hunger. So real hardcore humanitarian environments. And at the same time, if you talk to many people from Yemen, professionals from Yemen, including yourself, you always make the plea to look also at the health system recovery. You think, well, is that already time to do that? Are we? So could you allude to how we could have those different images of one's clear plea and advocacy for more health system recovery, looking at the future, and that image that we from the outside have of a real ongoing, more acute humanitarian disaster.
Okay, so yeah, thank you, Egbert. Yeah, that's a. I think we need to understand that the Yemen has been, suffered, structural vulnerabilities and issues for decades. It's not something that would be, the current conflict is like the end result of what has been happening over the last 3 decades or 4 decades maybe. It's true that the humanitarian situation in Yemen is catastrophic. Yeah, we have different health problems, political conflict, humanitarian, etc. But having worked in Yemen and lived in Yemen since my birth until the beginning of the conflict, and I've been also visiting Yemen during the conflict period between 2015 until today. So I've seen we still have maintaining some institutional presence in terms of public health services, even though they are totally they're reliant on international donors. But I still see the structures are there, and these structures need to be supported. Humanitarian NGOs or humanitarian agencies, they have been working in Yemen since 10, 15 years ago, and there have been like development projects ongoing which is provided by the World Bank and other agencies. But now all the focus, was put on emergency, which is totally fine. But after 5 years, 6 years of conflict, I think there should be a way to make a bridge between humanitarian interventions and development, and to try to support the health system. We do have infrastructure. It's poor infrastructure indeed, but we have health workers. We have basic components of health systems. We have been discussing how to protect the people against the financial health expenditures via different organizations, including the GIZ, and etc. So these things, I think, they have to be brought back into the discussions, and see how can we move in parallel or in tandem with the humanitarian support. So they are complementing each other, and if we invest more in development during this time, that would make it easier for the Yemen health system to recover, and will reduce the impact of humanitarian crisis on the long run.
Yeah, thank you. I assume that the whistling is at your end.
That's my son. Yeah, that's my sister. Yeah, it's home office.
Good. That's our lives these days. Great. Now, allow me one. It's not a follow-up question, but it's also a question which touches me. I have listened to your presentation, and you do the evaluation of the humanitarian cluster, how it was functioning in a specific context. In the process of you doing your study, could you also learn from maybe other similar evaluations which have done in other contexts? Because it's, of course, a topic which you could study in a range of countries. I don't know if it's being done, or were you quite unique in doing it, or did you find any other report of some sort, or just not done so often?
Yeah, there are quite, well, I would say a few reports, but not specifically on the health cluster itself, because the cluster approach is like a global structure. It's led by the Interagency Standing Committee, which is part of the United Nations Office for Coordination of Humanitarian Affairs, or UNOCHA. And the health cluster is part of it, and the cluster lead agency is the WHO. So there have been reports and evaluation reports for the health cluster for the cluster approach as a whole, but I haven't during the research period. I haven't find something specifically targeting health clusters, especially at least on Yemen. So that's kind of there's not a new insights to the existing literature on the global cluster as a whole, with a focus on the health cluster on Yemen in particular.
Yeah. No, thanks for that. Yeah, then as already announced, I would like to go back to Sphere, and you probably have been reading the argument which Jill has been posting, and I hope that others have also been able to see it in one of the boxes. And Jill comes up with some other arguments why, in fact, it may have been due to very specific incidents in Nigeria, at least, but even also in Afghanistan, to do with quite targeted ideas of why there was such a resistance. So, yeah, Svea, do you want this?
Yeah. I mean, it's a great question. So Jill points out very rightly that all of these things are playing out in very specific local contexts. So Nigerian leaders with concerns about global intervention, the context of the fake hepatitis campaign that the CIA carried out to try to find Osama bin Laden certainly damaged vaccination program credibility in Pakistan. So yes, all of these things matter. At the same time, what's enormously striking looking at interviews from these places, and I'm working right now in Peshawar. I hadn't started that work when I recorded this presentation a while back, so that's now informing my thinking as well. When you look at frontline workers and parents in Peshawar or Afghanistan or Nigeria, they're very clear that the root of their frustration is with the repeated provision of only polio vaccine, that someone makes the effort to come all the way to their doorstep and then doesn't make the effort to do anything further. And you see this, I think the most dramatic example of this is the demand refusals, where communities en masse will decide that they're not going to take polio vaccine unless they get something else they want. So that's a particularly clear example of that people are not anxious about the polio vaccine in and of itself. It's the dynamic of needing other things and not getting other things, particularly from their government. And of course, yes, everyone knows that the reason that polio is being so heavily pushed in these places is because it's a global agenda, right? So absolutely, the resistance is influenced by this knowledge that polio is a global agenda and it's not a local agenda. Yeah, so I would say that maybe we're closer than we think. I think that all of the things that you're mentioning absolutely matter, but they matter particularly in the context of this mismatch. If it was one campaign a year, it probably wouldn't matter so much.
Yeah, fascinating. Jill, do you want to still respond?
Sorry, I've just typed it in the discussion forum just to say I absolutely agree. I mean, I don't think we're arguing with each other. I think they're just multiple factors that feed into this very messy resistance conversation. And certainly with COVID now, I know everybody's kind of trying to jump in and understand vaccine resistance, and it's such a messy, complex issue. But I totally agree with you. I mean, in the other contexts that I've worked, this pushback where local communities have said what we really want is, well, what we would call horizontal systems interventions rather than vertical programmatic interventions is a very real I agree, it's absolutely upfront, as well as all these other messy other dynamics that drive all of that. So yeah, thanks.
Yeah. No, thanks for this conversation. Yeah, it always strikes me again, of course, as we say, also the current anti-vaxxing movement against the COVID vaccination. You also feel that it's a form of protest rather than being in itself against vaccinations. Sometimes, I mean, there's indeed so many other factors at stake. So that's good to know that it is also quite universal, even in the outskirts of Afghanistan, which is quite far away. Yeah, I think we have come to the end of our session. Thanks all the presenters for their work to put this together. You know, it's always a lot of work, and you have to stick in the 7 or 8 minutes, which is always a challenge. I think you all did very well. Very interesting presentations, and of course we would like to talk more, but I know that this forum is not really excellent for exchange of more ideas, but I think we've done well so far, and so thank you very much. And I think this was one of the last sessions we had in the HSR 2020, so I hope you also have been able to look at other sessions and part of the conference. And yeah, thanks a lot, all of you. And you know that all was recorded, and you could able to look back at it if you wish and see yourself again. Although, yeah. Okay, thanks a lot, and thanks for the support at the background at the conference room. I'll say goodbye to you.
Thank you. Thank you.
Thank you all.